This is a special unscheduled episode of the Coronavirus Daily Briefing. I'm Brian McCullough. A listener to this show got in touch Thursday or Friday, I actually don't remember when it was now, and asked if I would like to talk to a physician on the ground right now in Seattle area hospitals. Today we're going to talk to that physician, Dr. Greg Miller, Chief Medical Officer at Vituity. Dr. Miller, thanks for talking to us on short notice like this. Let's just start out real simple. I believe you worked a shift in a hospital last night. Can you tell me what the situation is in Seattle right now?
Yeah, I think it's we feel like it's a little bit the calm before the storm. It's definitely been busier with patients who have upper respiratory infections, coughs, colds, fevers, and things have been a little crazy with a lot of COVID rule-outs, a lot of patients with COVID. We've had several patients come through our emergency department and be admitted for COVID. We've got several patients in the ICU on ventilators with COVID. My hospital isn't as impacted as one of the other hospitals in the region, which is now running out of ventilators, and which are life support machines. But we think we're going to get there. But we do feel like this is, to a certain extent, the calm before the storm, even though things are getting really tight. We're very concerned that we're going to see an experience similar to Italy and Milan, or similar to what happened in Wuhan, where we're going to see a sudden ramp up over the next week.
Let me clarify something you just said. Yeah. You said that the ventilator systems are not over capacity yet, but you think you're about to get there?
Yeah, so one of the hospitals in the region has basically run out of ventilators and is looking around for other ventilators. My hospital, we have a certain number of patients who are always on ventilators. Just, any given day, you've got, a few patients on a ventilator in an ICU. And my hospital right now, probably we're about 50% higher than normal. So we still do have some ventilators. But once we get to like 200 to 300% of our capacity, we're going to start, we're also going to start running out. So there's conversations happening right now about how do we share ventilators? Where can we pull ventilators from? Maybe, we can cancel surgeries. And that's another thing that's happened is in the region, a lot of hospitals have canceled elective surgeries. So if you had a hernia surgery that was scheduled to happen, on Monday, it's not going to happen. We're going to be using those resources for patients who are sick with COVID.
I'm gonna really try hard not to ask you to prognosticate on stuff, but yeah. Are we assuming that you're going to run out of those vents this week?
It's hard to say. Okay. It's really hard to say. I think, and this is a total guess, I think had we not implemented the social distancing measures that we have, I think we would definitely have run out of vents already, honestly. It's hard to say what's going to happen with this epidemic over the next week or two. In Seattle, there have been some significant social distancing measures that have been implemented. My kids are out of school. Large events have been canceled. So hopefully we're going to see a decline in the rate of transmission of this, and maybe we will dodge a bullet here. But I think if we hadn't have done that, there would be a lot of people getting sick over the past few days. And once you get an infection, it's usually a week to 2 weeks out after you catch the infection that you get critically ill and need a ventilator. And again, we're not talking about folks maybe like you, Brian, or maybe a lot of your listeners. We're talking about folks who are elderly, infirm, with chronic medical conditions. Last night, we had a patient in our hospital who was on a ventilator and died in the ICU. I don't want to get into too many details of that particular case, but they were getting ruled out for COVID. And these are the type of people that we're seeing die from the disease for the most part. It's old folks with a lot of chronic medical conditions. This is, when we talk about running out of supplies, running out of equipment, running out of materials to treat patients, it's the oldest and the most vulnerable who are most at risk with this.
Can I ask you a question about the numbers? Like when I was just looking up the most recent numbers for the state of Washington, and it's approaching 600. But so when you work a shift last night, are you folks aware that, the numbers are probably X number higher than what will be reported tomorrow and that sort of thing?
Yeah, definitely. For two reasons. One is, if we're at the exponential phase of this growth curve, those numbers don't reflect numbers from yesterday don't reflect what's happening today. And then two, there just aren't enough test kits out there. So we don't have a good sense of the epidemiology of this. There was an initial study, like when the first couple cases got reported out of Seattle, that happened to be diagnosed just sort of incidentally by some researchers who are they were screening a bunch of samples, looking to see if any of these samples were positive. It wasn't that a patient was sick and a doctor's like, oh, I wonder if you have COVID, and send it off for a COVID test. That's not what happened initially. What happened was these researchers had, thousands of samples. They were looking to see, in addition to flu, did any of them have COVID, and they found one. And then when they did some genetic analysis, at that point, we had 2 reported cases at that time. And the genetic analysis between those 2 cases suggested that we had anywhere between something like 500 to 1,500 undiagnosed cases in the community. And that number has only gone up since then. But again, I'm hopeful that with all the social distancing measures, canceling schools, canceling large events, people staying home when they're sick, I'm hopeful that the rate of climb is going to slow down.
I want to stay on testing for a second because, we keep seeing on social media and other places all these stories of people that, I have all the symptoms. My doctor has requested a test. They won't give me the test. Can you give me a sense of that from the doctor's perspective? Like how many people could you be testing right now that you're unable to test or something like that?
Yeah, good question. I mean, we'd certainly love to test everybody who wants a test. The reality is we're running low on testing supplies. There aren't really that many testing supply. There aren't the capacity. So the capacity was promised by like last Friday. There was a promise that there would be 1 million test kits out to the American public, right? The reality was it was more like 75,000 were some numbers that I read. So we do not have enough testing kits to meet the demand. And fortunately, commercial laboratories, academic medical centers have had some restrictions loosened, so they're able to come up with their own testing processes and their own test kits. In the Seattle region, we've been really fortunate to have the University of Washington nearby, and they've just been doing a tremendous job of providing testing for us in this area. I think in a lot of other areas, you just don't have the same amount of resources. There just aren't, this was a disease that 3 months ago didn't really exist. There were 0 test kits for. The fact that we now have, even 75,000 test kits is actually a pretty amazing testament to all the hard work that academic scientists have put into this. But it's nowhere near where we need to be.
This is probably unfair, but I'm trying to get a sense of numbers. 5% of what you need, 10% of what you need, 30% of what you need?
It's a tough question.
Yeah.
Because what we need and our perception of this is influenced by what's available, So right now, like we have the test kits we need for the guidelines that we're using to test. So we're testing people who are over 60. We're testing people with chronic.
Are you already actively not testing people because you don't have enough tests on hand?
So again, tough question.
You can decline to answer. Yeah.
Yeah. I would say that there are probably a lot of people who want testing who absolutely do not need it. You don't need to get tested just for reassurance. Because if we had a treatment for this, I'd have a different answer. Like if you have a positive COVID test and we give you the COVID treatment, then yeah, absolutely, we would need to do a lot more testing than we have. But the reality is, what do we do with a positive COVID test? We tell somebody, stay at home for 14 days, stay away from others. And the reality is, like, that's just common sense, right? If you have a cold, if you've got a cough, if you got a fever, you should probably be isolating, whether it's flu or whether it's rhinovirus or whether it's COVID, right? So that's the issue here, right? What would we be doing if we had 1 million tests? We would probably be testing a lot of people, reassuring a lot of people, but ultimately not making a huge difference in the treatment for the majority of the individuals. I think where it really makes a difference is in older folks, where you want to know, like, is this COVID? Like, how concerned do we need to be because these patients are high risk? It makes a difference in folks who have exposure to large numbers of people. So teachers, physicians, food workers. It makes a difference in folks with chronic underlying conditions because you get a little bit more concerned about where the trajectory of the disease is. But for the average young, healthy person, it's not going to make that big of a difference. Now, it would definitely be nice to have, and I would love to be able to test people who come in just to reassure them, right? Like we do all kinds of tests in the ER just to reassure people. We test people for flu 3 or 4 days into their symptoms when we know it doesn't really make a difference, right? Like if, let's say you come in saying, oh my God, I need a flu test. We would absolutely love to do that. The reality is, the reason we test for flu in the first couple of days is there's a treatment that might help. After a few days of symptoms, that treatment won't work. But we still test for flu because we just want to tell people like, yeah, it's the flu. You should stay at home. You should, next year maybe consider getting a flu shot. So there is some impact in testing for the flu. And in the same sense, there will be some impact in testing young, healthy people for COVID as well, especially for the control aspect of things. But I think we can get to where we need to be in a lot of cases without testing. And that where we need to be is just telling anybody, if you're sick, if you got a fever, stay home from work, stay away from old folks, stay away from sick folks.
One more question about capacity.
Yeah.
I read actually something you forwarded to me that EDs in Seattle are doing things like converting lobby space into evaluating spaces and even evaluating patients in their cars and things like that. Can you, again, give me just describe the on-the-ground situation at hospitals in Seattle right now for patients walking in the door?
Yeah. So if you walk into an emergency department in the Seattle area, each emergency department has adapted their own physical space and resources to this. But in one emergency department, you might potentially be walking into a tent area outside in the parking lot. In my own emergency department, we have quickly built a separate sub-lobby with some construction. I mean, they've come in and done actually a really nice job in a very short time, putting up some walls to isolate this area and then sticking in a huge fan. So we've got like this sub-waiting room for patients with respiratory symptoms that we didn't have.
And also, I'm sorry, explain to me what a negative pressure space is too.
Yeah. So the idea is that it sucks the air out of that room and puts it outside, as opposed to a regular room that doesn't have any negative pressure. If you open the door, whatever air is inside that room will filter out into the lobby or into the hallway or into the room next door. So a negative pressure room, basically all the air that's in that room gets vented out of the building, like at the top, so that you don't infect patients.
And so at least one hospital in the Seattle area has quickly done a construction job to create rooms like that.
Yeah, many have.
Okay, interesting. How about the resources in terms of manpower? I think one doctor so far in the Seattle area has tested positive. Has there?
Yeah.
What's the situation in terms of the actual the medical people?
Yeah, the real manpower issue has been around childcare, honestly, with the school cancellations. And I think this is something for your listeners to think about. If these social distancing measures come to your community, are you prepared if your kid's school is canceled to have some type of plans for childcare? So that's actually been the real issue. There have been some issues around quarantines where a provider, a nurse, a PA, a doctor has come into contact with a patient who was later found to be COVID positive, and so they're out for 14 days. That's definitely been an issue, not just in Seattle, but across the nation. That's actually a big issue that people are struggling with. And, we hope that and this is another area where testing would make a real difference. If we're able to test those providers quickly and get quick results, and test patients quickly and get quick results, then we'd be able to get folks back to work. So like, here's a good example of where more testing capacity would actually be really helpful. A patient comes in, who has passed out. And so a provider walks into a room. So a doctor walks into the room to see this patient who's passed out, not thinking that this is a cough, cold, fever kind of patient. So they're not wearing any masks. The patient's not wearing a mask. And then you realize they passed out because they were coughing so hard that they passed out. And so now everybody puts on a mask. And the patient, let's say, had some contact with somebody who was from Europe or from China or South Korea. So suddenly there's this concern, this patient could potentially have COVID. In some cases, those doctors would be asked to isolate and not come back to work tomorrow until the patient gets a test and tests negative. And so those tests in some areas are taking 3 to 4 days. if they're able to test at all. So like, for instance, the state of Louisiana, I was told only had like 100 kits available in Louisiana to test. In Seattle, we're fortunate to be able to do hundreds of tests a day. But that's an example of where these doctors and PAs and nurses are being asked to go home. And suddenly you've got to scramble for coverage the next day. And we're not able to get people back to work. Whereas if we were able to get the patients tested, know that they're negative, that clinician would never have to go home. They could just stay and keep on working.
Final two questions. We're talking specifically about Seattle, and I wanted to do that because I feel like, unfortunately, y'all might be a little ahead of the curve in other places. Is there anything that those of us outside the Seattle region can do for Seattle at the moment?
Thin gloves. I mean, the personal protective equipment issue has been an issue. Like on my last shift, we didn't have the personal protective equipment that we needed. We're supposed to be wearing face shields, but there were no face shields in the emergency department last night. I would say you hunker down and prepare for this to hit your own community. I would advise not to go out and buy a ton of masks, let the people who really need those masks get access to those masks. And those will be the healthcare providers in your community, the clinics. They're buying masks from the same place you're buying masks from. And it's the clinics and the urgent cares and the smaller medical, communities, the skilled nursing facilities. They're the ones who really need these medical supplies because they're exposed to those patients. So that might be one thing.
Well, and then that was my final question, which is just your advice for anyone listening to this generally, what to do for themselves and their family right now.
Yeah, great question. So number one, I would say prepare for some type of social isolation in your community. What are you going to do if the schools close? What are you going to do if you've got some large event, a wedding coming up or something like that, that's going to end up getting canceled? So start thinking about that now. Another thing is, the standard advice. If you're sick, please don't go into work, whether it's COVID or not. Don't go to work. Don't go visit grandma in the nursing home. Stay home, wash your hands, cough into your elbow. I think, just to put this all into context, I think what the average American needs to understand about this is that you are going to be okay. This is not an incredibly lethal disease. Even though it is maybe 5 to 10 times as lethal as the flu, this is not Ebola. This is not SARS. This is something that the vast majority of young, healthy people will get. They'll have a little sore throat and a sniffle and a cough, and they're going to be okay. The reason why everybody's freaking out about this and the reason why we're taking such drastic measures in our society is, even though to a young, healthy person, the risk of something bad happening is so small, when you multiply that across millions of Americans, especially all the old and vulnerable Americans that we have, and then you divide that by the limited number of ICU beds and mechanical ventilators and ER beds that we have in this country, we're going to be completely overwhelmed. So if you tell somebody that, hey, there's a very low risk that something is going to happen to you and this disease is going to maybe multiply that risk by 5, that's still a very low risk for an individual. But when you go to a hospital and say, hey, you are already operating at close to 100% capacity day in and day out, and during the flu season, you're operating at 120 to 130% capacity, and now there's a disease that's going to come in and make you operate at 500% capacity. It's going to absolutely break the American healthcare system, like we saw happen in Italy. So that's why these social isolation measures are so important, is we need to blunt that curve. In my community, we've seen a huge spike in cases. And what we're hoping for the rest of America is that you won't see this spike. You'll still see the cases, but if you can blunt that curve over a period of months instead of weeks, like what happened in Italy and what happened in Wuhan, we will have the capacity to take care of patients. And it's not just the COVID patients that are going to need that care. It's going to be every patient, like patients who have heart attacks or strokes who are trying to get into the hospital and get the treatment they need. They're going to be blocked by all these COVID patients who are in the ICU on ventilators. Patients who need elective surgeries are not going to be able to get them because we're using those resources for COVID patients. So that's why these social isolate. I mean, that's why we have such a drastic reaction right now in the Seattle area and in other areas. It's not because, kids who go to class in elementary school are going to start, dropping dead of this disease, because they're not. Kids are going to be fine. The reason we're doing that is we don't want these kids going to visit grandma, giving the disease to grandma, and then suddenly grandma comes into the ER, ends up in the ICU, and that gets multiplied 5 or 10 times in each community hospital every single day, because we just can't, we don't have the resources to deal with that.
Thank you. Yeah, absolutely. Yeah. That's amazing. Thank you, Dr. Miller, for sharing that, and please be well.
Yeah, thanks. I'm washing my hands. Wearing whatever personal protective equipment I got.